New diagnoses and treatments for vestibular disease, a look at the future. That's the commission I was given. So let's start with that and talk from there. So I'm going to go to some basics now because several of you have not been here before, and words are going to be words that you haven't heard. And unless I get through this bit, you're not going to understand much of the rest. So basics for a few minutes. The first thing is the balance system has three parts. It has what you can see, your vision. You use that for balance, as well as seeing, obviously. Proprioception, that's a big long word for sensation. That's what the soles of your feet are telling you about where you are, and what the joints in your arms and legs are telling you your position is. And you use that information combined with your vision. And then you have what's called the inner ear. The inner ear is little balance organs. They tell you what your head is doing and how your body is moving without needing vision or proprioception. So imagine you're at the bottom of a coal mine and there's no light. Or if you have no vision, you can walk around just fine using inner ears and the sensations from your lower limbs. That works just very well. On the other hand, if you have, say, diabetes and you don't have any sensation in your feet, by using your vision and your inner ears, you can get around, perhaps not quite as well as somebody who's blind, but you can get around reasonably effectively. But if you lose any two of these structures, you're basically substantially handicapped. Wheelchair, walker, a major problem. If you have a balance system, that's the information that comes in. You have to have information that goes out to make your body move. And if you have problems with that, then your balance can be questionable, not just because the information coming in is wrong, but because, say you have arthritis and you can't move your foot properly, you're going to have trouble with your balance. Or you have difficulties with ability to move an arm or a leg in such a way. From neurological disease, this could give you balance problems. So these are balance as opposed to dizziness. Dizziness is a feeling, particularly what's called vertigo, which is a spinning sensation, is when the inner ear balance organ goes wrong. So that is different to trouble with your balance as such, which can be from information coming in or difficulties with putting the information out. And then you've got the central nervous system, which is the carrier for everything, and that, if it isn't working right, can give you problems. For example, if you have Parkinson's disease, you tend to have trouble with your balance because you can't move fast. So that's a sort of basics to start with. That's sort of 101. So, parts to the inner ear balance system. There are 5 balance organs in there, 3 semicircular canals. I'm saying all these things so when I mention them later on, you'll have a little bit of an idea. And then 2 gravity detectors. And you need all of them working right to be okay. So the semicircular canals, that's the bit when they go wrong, you get spinning vertigo. What they do is they keep your eye fixed on what you want to look at. So if you're walking along, you're able to continue looking at something while you walk because the semicircular canal activity keeps your eye wobbling at just exactly the same speed as your body's moving in the opposite direction, so your eye stays fixed. That's called the vestibular-ocular reflex. An example would be if I wanted to read this piece of paper here which says public meeting scheduled 2016, and if I'm shaking my head while I do it, I can still read because of my vestibular-ocular reflex. But if you do the exact opposite, and instead of shaking your head, you shake the paper, the vestibular-ocular reflex does nothing, and you can't read that. we have tests to measure the vestibular ocular reflex. So the other gravity detecting organs are the macula of the saccule and the macula of the utricle. My apologies for the complicated names. And they tell you where gravity is, because if you're avoiding falling, it's essential you know where down is. And that's how you know where down is. The gravity system of the inner ear tells you what down is. It has an extra aspect. It has some calcium particles in it, which you've heard as chalk. Some of you have had chalk problems, and the physiotherapists talk about chalk and moving it around, getting it in the wrong place. And movement of that allows you to know how your head is moving. We'll come to more detail in that. But those are the two things the gravity organs do. So those are the two parts of the system in the inner ear. So dizziness. Everyone has their own feeling for dizziness. So the aim of asking a patient what is wrong is saying, tell me what you mean by dizzy. And the reply is often, you know, doc, dizzy. And of course, you can't say what you like to say, which is shape up and think, how can I possibly know what you've got? What you actually say is, oh, can you try and tell me in other words? Which is what you do. And then you've got three problems. One is if the person is English second language, which many in Vancouver are, you can't use any words because you've got 500 words and you function with virtually nothing, and you can't describe it. You have to get an interpreter. So if you have a problem, get an interpreter if you have English as a second language. The second is some people just are useless with words. It's almost like English as a second language. They just can't say it. They know what they mean. They want to tell you, but they can't. And the third is the person who will tell you things which are really very interesting, but they're not quite really what you want to know about their dizziness. So often you'd say, well, tell me what you mean by dizzy. And then you'd say, do you remember when you were a little kid and you used to go round and round on a swing? Oh, that's it. Or have you ever had a little bit too much alcohol to drink? And of course, you always say this thing, oh, I don't drink, doctor. But most people have at least once done this, and they've had, and they say, that's what I get. So those are ways you can clue the patient in. These are clues to me as a physician of the semicircular canal problem. But one of the things I was commissioned to talk about was the future, and what has happened is, and we'll come to this in the talk, is we've got new tests to measure the gravity detectors, and because of that, we are realizing that many things which were regarded as not from the inner ear, in fact, are from the inner ear. And it is important to realize this because obviously it takes time for information to disseminate. And I, as an elderly practitioner, learned this by seeing patients and realizing. But if you are trained as a general physician, when you leave the medical school, it's hard to keep up to date with the mushrooming information we've got. And new information, you may be the person who takes the article to your family doctor and says, I've got this. And he may learn a lot from you. He may not, and he may think, oh, not another person doing this to me. But you may give him the article he needs to learn something. And about dizziness, there is something to learn. So everybody has a unique sensation. There's nobody with exactly the same thing because the system can go wrong. It's so subtle in different ways that your sensations are all different. So getting an idea is the first thing. So that's just the general concept. Tell me what you mean by the word dizzy without using the word dizzy. Now, we have 5 senses. There's a sixth sense, intuition, which is very good for detective stories and this sort of thing. But basically we have 5 senses. They all have one thing in common. They are external stimuli. Everybody can look at them. You can feel silk and say, do you feel that? It's different to nylon. It's different to tweed. You can feel it. Taste. You can compare somebody's ice cream with somebody else's ice cream. Sight. You just need a glimpse to know somebody's there and who it is. You have sight as a sense. You can compare what things look like. Hearing. You don't need much on the telephone before you know who's speaking. This is external stimuli, and smell is the same. You can smell something, say, smell burning. Yeah, oh, so do I. Let's look for it. These are all external, and because of that, they have received much more attention than balance. The sense of balance is silent. You only know it's not right when it's wrong. We have no words to describe it. That's what I've just said earlier on. Because it is silent till it goes wrong, you can't compare with your friend and say, have you got this? Because they haven't got it, because they haven't got anything wrong. So it is difficult to get it out. So silent balance system, therefore no vocabulary, therefore difficult to tell people about, and people don't understand what you've got. When people don't understand what you've got 4 limbs, 2 eyes, 2 ears, you seem to work reasonably well, you don't get a lot of sympathy very often. So, no sympathy. That doesn't help your ego and confidence, so you don't do so well from that. So when I'm talking about dizziness, I want to know, do you have a sense of movement? Is there a feeling you're moving? And if there's a feeling of movement, does it go with certain things which are frequently associated with malfunction? Nausea. Do you feel nauseated? That's a miserable thing. Do you remember that advert for the 649 with the headache? Well, nausea would go very well in that advert because it makes life so miserable. You wouldn't care if you'd won the 649 if you're chronically nauseated. One of the big problems with inner ear disease is it causes stress. It's the classic fight or flight reaction, the excitement reaction, which in small part is fun. It's the kicks in skiing, in fact, or in many of the vestibular stimuli we have, merry-go-rounds, fairground rides. It's that turns you on. It makes you feel good when it's limited, when you can stop it. If you've got it all the time, it isn't so much fun. And if it goes to the severe fight or flight reaction, you get tachycardia, you get sweating, you become anxious, you get a catecholamine release, you can collapse from it. You can need to pass water quickly, things which can be quite embarrassing. And it is extremely distressing. Permanent stress, depression. Depression can follow this. Now, having gone through that, let's get to balance. Trouble with your balance. Now, if you're younger, if you fall over, it's an inconvenience. If you're older, you break or you bruise severely. And if that happens, that's miserable. You just need to have it happen once and you think, I'm not going to do that again. What do? You don't do the things which keep you busy and active. You stop going around. You stop using your muscles. You lose your muscles. So when you do need to take a quick step to catch yourself, the muscles aren't there to do it. The fall is more likely. Result, permanent stress, depression. Now, anyone with a significant other who is miserable all the time has a significant other who has to tolerate the misery. And it may be that the significant other can also have depression through having to tolerate the constant lower mood of the individual who is suffering. That is something which needs discussed with your family doctor. How you want to address it, that is not my field. One of the things I could confidently say was psychiatry was a subject which I intensely disliked in medical school, and my views have not changed. So I don't get into that. But certainly it needs addressed, and if your mood can be improved, your coping skills improve, your atmosphere improves, your symptoms don't change, but you manage better. So let's get to what's new. That's a base to start from. Right. What things that have come on since I started? What's new is since I qualified? So that's a long span. And so the vestibular ocular reflex, fixing your eye, was what we all understood when I started this stuff. But when you talk to patients, they'll tell me, I turn my head and my eyes catch up. Or when I stop turning and I'm driving the car, I feel as if the car keeps going around the corner. Things which indicate that the balance system isn't switching off at the right point, or your eyes aren't coordinating satisfactorily with your ears. With this, slight unsteadiness. In itself, an inconvenience once you're used to it, but add that to being present all the time, what do? You move your head less frequently. You move your body instead of moving your head. Less muscle activity, less muscles, can't move as fast when you need to, increased risk of falls. Okay, let's just drop back. The vestibular ocular reflex keeps you looking. Is that too loud? It's sort of echoey. Is that too loud now? Is that all right? It keeps you looking at what you want to look at. So let's say you're walking down a busy street in Vancouver and there's a nice sign and you're reading it. You can read it as you walk along. But if you then decide, I want to look and see what's in the shop window, you glance off. That is voluntary suppression of the vestibular ocular reflex. That's entirely normal. There are other reasons you have to suppress this. If you're eating an ice cream and suddenly there's a nasty taste appears and you've been reading your sign on the street side, you'll suddenly look at your ice cream. That's switching off the vestibular ocular reflex and looking. But if you have a problem with the vestibular ocular reflex, when you switch it off and you move your head, the catch-up is wrong and you feel dizzy. Touch is one way you can have it switched off. If you're walking along and somebody goes and pokes you, you look, you switch off what you're doing and look. How many of you have driven to the shops, quarter of an hour in your car, the radio's on, you get there and you get out and you think, how did I do that? What did I see? And you can't remember anything. But if you're driving along and you suddenly at the corner of your eye see a car coming that shouldn't, that's switching off the vestibular ocular reflex in order to catch it. And what you don't want is to do that and have your eyes go funny and not be able to look properly. Similarly with hearing, somebody calls your name in the mall when you're looking in the window, you instantly look, switching off the reflex. You don't want to stagger and look embarrassed. One of the big things that people will say is that I'm unsteady, and when people see me, they ask me if I've been drinking. And that is very off-putting to somebody who is perhaps a teetotaler, lifelong teetotaler, very difficult. And some people will actually stop going out as much because of that. And obviously sense of smell and alerting, that's the classic, you hunt down wind of the animal, because if you get upwind, it can smell you. That's a classic. So smell, burning is the other one we're interested in, or gas. But animals have been doing this to survive. And that's the other thing that the balance system does. It keeps you alive. You don't think about this. And we are fortunate in living in, for want of a better name, the civilized world. Because 10,000 years ago, hunter-gatherers moved from place to place. The local Aboriginals, Native Indians here went from place to place where the salmon came in, where the berries were. And all over the world, that was the style. That was what people did. And if you broke a leg because you had bad balance, you died. And if you look at the archaeological remains of Neolithic men, there are virtually no healed broken legs, but there are a lot of healed broken arms, because you didn't die if you broke your arm, you just struggled on till it healed up. It might not have worked quite so well, but it didn't kill you, whereas broken legs did. So we're fortunate that we have somebody who's going to supply food if we can't get out and do it ourselves as part of the civilized world. Let me just, one other thought about alerting. If you were in Damascus at the moment and you were walking down the street to the shops, your level of alerting would be considerably higher than if you're on the streets in Vancouver, because you have serious concerns related to safety. So let's just talk about what I'm going to call visual vestibular mismatch. Several names for this: visual vertigo, visually induced dizziness, visually induced imbalance. And this is where the balance system, the gravity detectors, aren't quite working in sync with vision. It's important that the limbs, the eyes, and the inner ears work together. And if they get out of sync, you have a problem. So if your eyes are able to work fine, and your ears are able to work fine, but they don't join together, that produces a sensation of confusion in your balance and dizziness. The classic example is one that I was involved in. It was a research project about using gentamicin, which is a medication we use to treat acute dizziness and Meniere's disease. And I was doing a paper for a meeting, and I thought, shall I do this? It suddenly became a lot of work, just as I had to get on and do it. So I rang up some people and said, did that treatment work? And they said, oh yeah, it was great, doctor. If you restored my life, I can go to the shops now without being afraid I'll fall and get embarrassed and being accused of drunk, and the taxi won't take me home. And it was great. It was very satisfying, actually. But several of the people said, you know, doctor, I can't go to the shopping mall anymore. All the movement around me makes me feel dizzy. And I didn't have that before this treatment. In other words, the treatment did damage to the inner ear, causing this symptom. That's vestibular dysfunction, and then the eye isn't telling the ear what to do. Why does this happen? Well, the eye has ordinary vision, what you look at, but it has that thing which, when you're driving in a car, peripheral vision, which is a different system. That one's the one, if you happen to be the Neolithic man on the plane and you get a lion coming out of the corner of your eye, you want to know that. So that's pretty alerting. That's why you have this, so you can turn and run. So that optokinetic reflex is part of a reflex we can measure. And if ever you've had any balance tests, we do a stripe thing across the wall and measure the stripe reaction. That stripe reaction, the speed it goes past, if you're walking, you're getting that stripe reaction from the lines of the lampposts. And it tells you how fast you're moving. Your inner ear is also measuring your movement, and those two have to gel. And if they don't, you get trouble. And that trouble's in the shopping mall, the supermarket, escalators, checkered carpets. Your people will come in, stripy shirts. If I wear a stripy shirt, some of the patients will come in and, because they've had this reflex, they got dizzy from it. It's upsetting. And what do you do with that? You stop going to the shopping mall. Or you go late at night, and you go when it's quiet. So these are visual vestibular mismatch symptoms. So let's just talk about Vimps. Vimps, there's another long set of words. Vestibular evoked myogenic potentials. We'll call them Vimps. And what they are sound responses, noise responses to those gravity-detecting organs of the inner ear. First discovered in the 60s, start to be researched in the 90s, and a clinical test came out in just after 2000. So this is relatively new information. So at a clinical level, we can now measure these organs, which we couldn't measure before. So now you can actually test them. And of course, as soon as you test them, you start realizing that people who are complaining of difficulties with just not feeling right, or I feel funny when I'm out and about, I don't like the shopping mall, the supermarket. This was often regarded as agoraphobia, psychiatric. Now, no disrespect to psychiatrists, but people don't like being diagnosed with psychiatric disease. Whether it's one of those things, whether we like it or not, that's just the way the world is. And accepting how the world is, you can try and change it, sure, but with these tests, we now have a method of looking somebody in the eye and saying, we can measure there's something wrong with you. That's really new. And that's really reassuring, particularly as the patient will already have seen 2 or 3 people who said, in the nicest possible way, you're nuts, or some tactful way of saying that. You follow up, I'm terribly sorry, there's nothing I can do about it. They'll still go out and say, doctor, at least I've got something wrong. And they're happy with that. So it's actually been very useful. These tests are still being researched and expanded. Acute vertigo is clear-cut. If somebody comes and says, I've got that, that's an international sign. Transcends language for vertigo. It's the subtle ones that are hard to deal with, where you do need good language, where you have to understand what the patient's telling you. I had a lady who came in and said, I felt like I was in a typhoon. I thought, a bit funny. Then I thought about, of course, typhoons are spinning winds. This was actually a vertigo description from somebody from China. It's where you come from affects the words you use. After you've had acute vertigo, which is the semicircular canals, the balance part is the gravity detectors. They're more subtle. They don't give you the big thing. They give you vague imbalance and steadiness, not walking in a correct direction, more subtle difficulties. But people with that have abnormalities on their Vimp tests. We can now measure that and say, this veering off thing, it actually is something wrong with you. You've got something. Frequently from trauma, dizziness occurs. I don't know how many of you have traumatic origin for your dizziness. You get symptoms, and we'll come to some slides with that in a while. So this is a project which BAD supported to look at peripheral vision and rehabilitation for visual vestibular mismatch. It's a study with Dr. Acera, who's a vestibular physiotherapist, Dr. Mallis, who spoke at the last meeting, myself, and Dr. Emily Kirshner, who is a professor of physical therapy at Temple University in Philadelphia. She came across and spent some weeks with us. And the purpose of this study, we're still in process, and we don't know the result yet, is to use the equivalent of horse blinkers. Do you remember what horse blinkers are? Most of you are old enough to do that. If you said that to a young kid, they wouldn't know what you were talking about. And by cutting down the peripheral vision, trying to stimulate visual responses of patterns which make you feel too dizzy to do the test, with less peripheral vision you can do the test. Then we're trying to take back the peripheral vision, see if you can get people to have an increased toleration of these symptoms which stop you going to the supermarket. So that's a project which I thank you for giving the support to allow us to investigate. The results are pending, and I'm sure hopefully we'll be able to give you some information about that next year. Going back, here we are. Test of balance function. All right, test of balance function. This gives you some idea of where we're going. And it sort of, if you look at this, you can see what's been available for how long. And it shows the mushroom of knowledge developing. One test for 100 years, one test for 30 years, one test 10, one 6, and one 3. You can see how fast the new information is coming out about balance assessment. VOG, that's the water test that you get when you have that caloric test, described by Robert Barani, got a Nobel Prize for it. Brilliant test, still useful. We still don't know why it happens, but it's clinically relevant, and we based treatment on results from that test. We put gentamicin in the bad ear in many AS patients who have an abnormal test. Posturography, that's computerized dynamic posturography, equitest. I think I have a slide on that. What is it? Right, here we are. This is the slide. This is a piece of equipment we have at VGH. This is unfortunately very expensive. There's one there. I think there's another one at GF Strong. There's one in Calgary, one in Winnipeg. Toronto doesn't have one. They can't afford it. And there's one in Montreal and Halifax. And this test measures sway. It measures how much you sway while you're standing still. And in people with bad balance, they sway more than you and I. I being the people who haven't got bad balance in this room. And it is a measured abnormality level, so we can tell when somebody's balance is poor. It is not a diagnostic test, it is a confirmatory test to measure there is something wrong. The diagnosis of what is wrong is based on the history and the examination. And there are 6 parts to the test. It's done with the feet standing, Romberg test, the standard Romberg test that was described by Henrik Romberg. And at that time, he described it in 1848. If you had a positive test, you had syphilis. Not the case now. And then with eyes closed. Those are 1 and 2 on this. Then the third one, the surround that you're looking at, the blue clouds there, sways as you sway. So your vision gives you wrong information. And then 4, 5, and 6, you do 1, 2, and 3 again with the platform you're standing on swaying, so your feet are maintained at right angles. So you have to decide whether your feet are right when they're incorrect or your inner ear is right. And if you fall over, it's because you're not listening to your inner ear, because you've got a bad balance problem. 6 is when the surround sways, misinformation from vision, misinformation from feet. Your inner ear has to maintain your standing. So that's this test of sway. Vimps. I'll just briefly talk about them. Vimps are the sound response to noises. And we get measured responses of the muscle in the neck and the eye with the C-vamp and the O-vamp. So the research project we're doing with BAD is to see whether the amount of sway people have on the sway machine you've just seen, and whether their vamps are normal and abnormal. And we thought, well, sway, That's related to gravity. So that should be the same, or should have abnormalities on the eye balance organ and the neck balance organ tests. And we thought, so obvious, logical. There is literally no association between the two. That's what we've found from the work we've done. They are not associated. Why? It's because the balance is the feet. And the eye and the neck are related to head movement. Now, you don't want your eye and your neck responding to your feet. If you imagine that lion that we just had in our peripheral vision, we decided to shove off and run, you'd be looking over your shoulder. But if you're taking notice of where your head and neck are related to your balance, you fall over and you get eaten. So it's important that the balance, the lower limbs, are closely associated but disconnected with the movement of the head and neck. And that's what we've actually found out. We assumed that was completely wrong. That was a complete surprise to us that we got this. And we did it 3 times before we became convinced, hey, and then of course it dawned that moving your head and moving your body are, obviously, you've got to have your head attached to your body, but it's important that your head can move independently of your body, and we're measuring 2 separate parts. That's actually new information. We're presenting that in Korea at the next Barani meeting. So that's a recent study. Now, let me just go to these organs here. This is something that looks terribly difficult. Have I got a marker? I haven't. Oh, wait a minute. Does it do it on here somewhere? No, it doesn't. Have we got a mouse? Yeah, there's a mouse. Does it do anything? Yes, it does. It does. There's a mouse. This is the chalk, the otoconia. These are the clumps of calcium that fall off, get into the posterior semicircular canal, and give you benign paroxysmal positional vertigo. That's the stuff of it. It's electron microscopy. They're tiny. That's what they look like. For people who really want to describe things, this is a tetrahedral. It's got 12 sides, these things. You can see they've got 3 little triangles on the ends, six in a circle and 3 on the other end, 12-sided. And they are connected together. This EM doesn't show it, and there are technical reasons for that. But they're connected together, and they move. But they don't move as a unit. In certain animals, for example, the octopus, it's a single clump. It's a single crystal. In other words, it doesn't need to move. But these move separately from each other, and that's because when you move, these particles are 3 times the weight of the fluid they're in. So if, for example, I move forward and stop, as I move forward, these particles get left behind because they weigh 3 times as much and they've got an inertia, they stop. And then when I stop, they keep going ahead. So, makes sense. Now let me tell you the new information. There's 2 sizes. It was discovered in the 60s there were 2 sizes. NASA spent millions because astronauts get dizzy and vomit. And they didn't want spacemen coming back to capture Russia, who were vomiting and couldn't capture Russia. It was simple. So they did millions, and that's where the Equitest actually came from. But there are 2 sizes, and what happens is when you move, the 2 sizes move at different speeds because they have different inertia. And that differential is what these structures here pick up. This is the utricle, this is the saccule, maculae. We've talked macule, utricle, macula, saccule. And this area in the middle you can see has little ones, and this at the edge has big ones. And so when they move, if you stop, these ones get left behind, these ones get left behind, and these ones don't get left behind as much. And then when you start again, they go in the opposite direction. That movement is detected by these sensory cells under here, and that's how the balance system detects movement. The other thing is, of course, these weigh a lot, and they weigh down on the structures here. That's how we tell where gravity's coming from. Because if you're at 45, imagine this at 45 degrees, it pulls in a different direction. So it does two things. It detects acceleration, deceleration, and gravity. That looks bad. Oh dear. Mm-hmm. Yeah, good. That is a sensory vestibular cell. It's an electron microscope study of it, and we don't need to look at it in great detail, but it's got long hairs and little hairs. And at present we don't know why there's long hairs and little hairs. They're linked together. And when movement occurs, flow of fluid occurs across these because the calcium particles squeeze the fluid out, and that's the fluid that flows across these, stimulating these hair cells to work. This is all sort of relatively new information. Doing it again. What's that? Oh, that's a clever... clever girl. Well done. Thank you. Right. Oh. Wonderful. Youngest member of the audience, I think, as well. It's always the young people who know this stuff. All right. One of the things that's happened recently in all of medicine is the explosion of the effects of MRI. For example, with acoustic tumors, which is a tumor that some people who have dizziness have, very, very, very rare. But it's looked for because it can be serious. MRI picked this up and changed the management of how this whole field was done. But more recently, we're getting functional MRI. We're doing things to the brain and measuring in rapid time what is happening. And there was an announcement, I think, on the news last week of a program where it's now possible to tell from MRI what's minimal traumatic brain injury and what's post-traumatic stress disorder. Now, neither of those are particularly related to dizziness, except they both have dizziness as a symptom. Clearly, with post-traumatic stress, you can't attach dizziness from the ear to that very easily. But with minimal traumatic brain injury, you can, because it is very hard to injure the brain by some form of trauma, a bang on the head, which is what this is, without banging the skull, which is the ears. And in the temporal bones, the inner ear gets shaken at the same time. So you get minimal traumatic brain injury and dizziness. It is quite possible a lot of the dizziness is not actually from the brain. Sidney Crosby had inner ear dizziness, although all the stuff was about minimal traumatic brain injury and so forth. That was what was always said. But in fact, it was his ears that were not working that well. And one of the things you have to think about with this is, why is that the case? Why do hockey players get that? And of course, hockey players don't get that anymore than anybody else. Everybody gets that if you get banged on the head. What hockey players have is the ability to recover from it well enough to get back on the ice. So they probably have a better balance system. They probably have a better balance system in the first place because they can ice skate so brilliantly. But they probably have a better repair system for these calcium particles which get knocked off. The calcium particles are replaced every 2 months. There's a constant going circuit. And injury, which can either be trauma or inner ear disease, which is non-traumatic, where you get damage, reformation and restoration of function is probably impaired. And that's why you have ongoing symptoms. Hockey players are largely lucky, although we can all quote examples of ones who aren't lucky, and the football players who are getting all these nasty things and they're writing about, they're getting these things damaged. And I guess if you get paid enough, you're prepared to sacrifice your body, aren't you? I guess that's... Do we feel sorry for them? No. Interesting thought. All right. What's new? Well, what's happened with balance physiotherapy? It started in 1945 with Michael Cooksey, a GP from the centre of England, working in a rehab centre with vets who were injured, and Sir Terence Cawthorne, the King's otolaryngologist. And they both sent a paper into the Royal Society of Medicine, and they got them accepted, and they presented it one after the other, a bit like Darwin and Wallace. And the guy who got the credit, Sir Terence. But Cooksey, a GP, worked it out from nothing, how to rehabilitate by getting people up and getting them going and working on recovery, rehabilitation. That was the beginnings of balance physiotherapy. John Epley, 1991, got a publication of his maneuver, the Epley maneuver, which you may have heard of, for those of you with chalk in the posterior semicircular canal. It took him 10 years to get that published. He was investigated by the Oregon Medical Association for charlatanism because he said he could cure it. Amazing, eh? He got it published, and of course, he's got his name in the book now. He's famous. Died 2 years ago. Very nice man, actually. He used to go to the Brownie meetings, present there. He was revered. But he was the man from which really vestibular physiotherapy arose, because that was the first time something really positive could be done. Although, obviously, exercises, vestibular exercise, head movements, body movements, find what you need that's wrong, do it the vestibular physiotherapy way, and you improve. One of the biggest problems with dizziness is that you've got a damaged system. You may have more than just your ear. You may have your eyes, your perception. You may have neurological disease. The system is damaged. And because it's damaged, it can never get back to normal. All it can do is get back to as good as it can be, given the amount of damage that it's got. And when you're doing balanced physiotherapy, the process is to maximize. And then you have to keep doing it to stay maximized. The analogy I give is if you could imagine the winner of the 1,500 meters at the Olympics, if he went and lay on a sand dune for 3 weeks and the others kept training and they ran the race again, he wouldn't win. You've got to keep doing your balanced physiotherapy. You won't get to normal because you've got a damaged system, but you'll get to as good as you can get. Fall reduction. It's a Google thing. Look up the risks. But there are some obvious things. When you get significantly bad, don't talk and walk. If you talk, you have habitual behaviors, one of which is glancing to the person you're talking at. That means you're not looking where you're going. You trip up and you fall. Don't talk and walk. Walk with your friends silently to Starbucks. Sit and talk. Get up. Walk silently home. One of the things that you may have noticed in kids' playgrounds now is that they have this rubberized matting. And you walk on it, feels a bit funny. But if you fall over, it hurts a lot less. And they're actually sort of starting to put that into old people's homes, because if you fall over, it's much better just to bruise than to break. So that's a new development based on dealing with problems. If you have more than 3 medications, it's recommended that you get them checked out. No disrespect to family doctors. It is the toughest job in the world for doctors because you've got this mushrooming knowledge cloud and you have to try and keep a pace of some of it. And when a patient comes in and says, I'm feeling faint, you'll give them a medication. And if they come in again and say, I'm still feeling faint, you can do one of 2 things. Spend a bit of time working out how it's changed, or you can say, let's give you another one. And when you've got to too many, you fall over because you've got so many things. One of the ones we used to have, unfortunately it stopped, there was a medication we gave which stopped the blood vessel shrinking when you stood up, so that when you stood up, your blood pressure didn't go up. Then we gave people a diuretic, which reduced the volume of circulating blood. And then we put them on a sedative because they were a bit anxious, which caused postural hypotension. So these people would stand up and fall over. And that's the simplest example. But if you're on several drugs, review them and see if you can get off one of them or cut the dosage, because that has potential for benefit. Osteoporosis check. How many people in this room know they have or don't have osteoporosis? All right. It's not a fall risk itself, but if you fall, what you don't want to do is fracture your femur. There's a small death rate with that. There's a miserable operation that goes following that. Osteoporosis has managements to optimize thickening of the bones and prevent thinning, so that if you fall, you bruise. There are few advantages to being fat. Osteoporosis is one of them, because you bruise, because you've got the soft carpet to land on already, built in. So just briefly, migraine. I have a pet peeve about migraine. 1 or 2 of you may have been told you have vestibular migraine. That is a moving target. Neurologists rarely tell you have vestibular migraine. They are much more reticent about diagnosing it than otolaryngologists. So, how much training does an otolaryngologist get in migraine? Not a lot. How much does a neurologist get? A huge amount. Is there a concern that otolaryngologists may be overdiagnosing migraine? There surely is. On the other hand, if you're getting recurrent dizzy spells, there are some drugs for migraine which you can try, and if you're lucky, you might get benefit. So it's not without consideration, but it's not the panacea and diagnostic grouping which dizziness used to be 30 years ago. When I went to practice, if you said, I'm dizzy, you were diagnosed as Meniere's disease. Routinely, that was the diagnosis. And the fact that you didn't have any hearing loss, you didn't have any tinnitus, was irrelevant. You were Meniere's disease. Then somebody actually said, let's have some criteria. Criteria were set up. Meniere's is rare. Vestibular migraine is rare. Criteria are being set up to deal with it, and it is not as common as we think. So if you've been told you have that, be a little cautious. On the other hand, if the medications aren't too effective to you, maybe it's useful. I have stopped seeing MSP patients, but just before doing so, I was starting to use calcium active agents on the basis that if I could change the calcium metabolism, which is associated with producing the chalk crystals in the inner ear, perhaps I would have some effect. I have no idea whether it's of any benefit. On the other hand, it was worth a shot because these people weren't getting better anyway. So that's something to think about. There are a series of medications we use for that. Mm-hmm. So use it or lose it. That's where we're at. To some extent, you have to try and keep active. Try and do things which you can do within your capabilities. Don't go ice skating. Even if your grandchild says, "Come on, Grandpa," don't do it. Don't paint the other story of the house. Don't go up scaffolding. Line skating's a bad idea. Cross-country skiing in powder snow is not too bad. Even downhill on blue runs, powder snow, probably okay. No black runs. No skiing on ice. Ride a bike in Stanley Park, where if you fall off, you screw up your knees. Not on the road where you get run over by the bus. So this is just an overview. We have a meeting in Korea. We're going to present some papers. We'll have new information from that, hopefully something striking. And maybe next year we'll have another meeting like this.